this. These are my disclosures, nothing related to this talk. By way of outline, I think it's important that we talk about the ethics of penile transplant. We'll talk about patient selection and why that's important and how we can potentially use patient selection to determine the type of transplant. We'll also look at preclinical studies that led up to the transplant itself. This was work that was done in my lab, and actually I'll go over the results of the Penoscrotal transplant at Hopkins. I would be remiss if I didn't say that this is a team science. This is the definition of team science. This is the group of people that actually did the work for our patient. You can see here this is a collection of residents, fellows, plastic surgeons, and 2 urologists. Myself and Bud Burnett, who I think presented here last year, were the urologists that were involved, and Rick Redette, who I think there might be a pointer here. Potentially, Rick Redette here, he's plastic surgeon, and actually he was the person that came up with the concept of like how we could do a complete abdominal wall, scrotal, and penile transplant. And I'll show you the work that was done. Our case was just, our case report and the work that we did was just published in the New England Journal of Medicine. So let's talk about the ethics. This is really a polarizing field because there are a number of people that are really against penile transplant. But what we have to think about as physicians is allowing patients to decide on their own the fate and risk associated with any transplant. And this is in line with the patient's own right of autonomy. This is a transplant for a benign condition, and are we potentially putting this patient in harm? Well, the reality is the process to transplantation, especially penile transplantation, is one that's very long. This was something that actually took years to actually consent our patient. There were a number of steps. We went through the IRB. There was a data safety monitoring board that actually was with Rick when he consented the patient. And this was a patient that we saw over many years and had multiple discussions. So really, the process of consent and doing this is one that it takes a long time. And I can tell you, this patient was fully informed. The question, and this is what the field is saying, is how can we give a patient with a benign condition immunosuppression lifelong that could put this patient at harm? Well, we've decided, and the group at Hopkins has really said, well, listen, we're giving this patient an acceptable level of toxicity from immunosuppression, and more importantly, there are new approaches to actually reduce immunosuppression completely, and I'll share that with you. And Andreas, who is the very first person, who is the urologist and actually vascular surgeon, he does renal transplants from South Africa, was the first person to do 2 penile transplants in South Africa, and I'll review that. He said this at the SIU in 2017. He said that all patients have the right to be normal. So remember that when we're thinking about a penile transplant. So who are the people that are eligible? This is the potential list. I'm not saying that that the field is going to do a transplant for each one of these indications, but this is where we are. The two first transplants were done for circumcision. This was done in South Africa with Andrea, and these were very successful. What I will tell you is the first patient actually ultimately had rejection and needed the transplant resected. He still has a stump, but unfortunately he had rejection and needed portion of his penis removed. Traumatic injury. So traumatic injury, and this is sort of where we were with our association with Washington, D.C. and the DOD, we were thinking that we could potentially do a transplant for a patient that was in the military and lost their penis secondary to a blast injury. And iatrogenic. I will point out that in China, a penile transplant was done over 10 years ago, almost 12 years ago, for a man that lost this penis. It was he was removed due to a psychological condition that he was in, and he actually underwent a transplant, and it was ultimately removed. So I think that represents and points to you need a patient that's fully informed and a team approach to do that. Penile cancer, the group in Boston at Mass General did a transplant for penile cancer, and then congenital conditions for things like bladder exstrophy, where patients are unable to have lost their penis, secondary closure of their transplant. And this is something that we have a lot of expertise in at Hopkins. And everybody asks, what about transgender? I'll just make the point, I don't think that will ever happen. If you want to talk about it more later, we can. So what about traumatic genital loss? So how common is this? Well, the DoD registry from 2001 to 2013 pointed that there was 29,000 traumatic injuries, and 5% of those were actually of the GU system. The most common was the scrotum, and the second and third common was the penis and testis. And I will point out that that's exactly what happened to our patient. He lost his scrotum, testes, and penis from a blast injury. So this is the problem. This is actually this is a patient that we saw at Hopkins. He was seen by Rick for a penile radial forearm Phalloplasty, and then ultimately referred to me for an IPP. So this is what he looked like. And I only put this up here because when you think about it, this patient has the ability to do any skin grafting. The abdominal wall has had grafting. It has an X-lap, has a colostomy, and has lost a portion of his penis. So this is sort of the patient that we were choosing for our first transplant. So what about phalloplasty? Important to point out that this actually gives a nice cosmetic result. The penis can be very normal appearing. Cosmesis is good, and you can actually get sensation. However, the complications associated with this as it relates to urethral complications are very high. Some would quote as high as 50% or more. And importantly, when we go to place an IPP in the phalloplasty, it is fraught with problems related to erosion, infection. And we oftentimes can't put in 2 cylinders, so we have to put in 1 cylinder. They're not able to have a good rigidity. So what is our alternative? So Sammy, who is a plastic surgery resident in Rick's group, actually did the first cadaveric studies to look at the innervation as well as vascular supply of the penis and scrotum. And this is a paper that he published actually in 2014, which shows that for example, the transplants that were done in South Africa and in Boston, all that had to be done for this was a anastomosis of the dorsal and cavernous arteries. And this is sort of what was done in Boston and South Africa. There was a stump, and then the dorsal and cavernous arteries were done. A urethroplasty was performed, and what they have shown in that from their clinical results is that you actually can have an erection, and you can actually have normal erections with this approach. And this is the cadaveric studies that were done. They were doing small arterial vessels. They were doing nerve anastomoses. And this is sort of known. But what wasn't known was the vascular supply to the shaft of the penis and to the scrotum. Remember I told you about the Chinese patient that had a transplant? Actually, that transplant rejected because they lost the skin of the shaft. The skin was lost. And it's because of this. Here you can see that the external pudendal artery and vein, they give vascular supplies to the penis as well as to the abdominal wall and to the scrotum. And this is his cadaveric dissection. What he did was he injected different dyes, a blue dye and a green dye, and showed that if you inject the cavernous artery, the dorsal artery, this is what supplies the glands. However, the shaft, the skin shaft, and the scrotum and the abdominal wall is from the external pudendal. So that told us that we had to do this vascular anastomosis on top of the cavernous and dorsal. So this is the final result here. This is sort of the conclusion of that study. So if you're thinking about a transplant here, which is what was done in South Africa, you can just do the cavernosal and dorsal arteries. If you're thinking about a proximal, well, you could also do the cavernous and dorsal arteries and bring in the external pudendal artery to supply the skin. And if you want to do the abdominal wall as well as scrotum, there's no doubt you have to bring in multiple vascular anastomoses from the external pudendal. So this was important because our patient needed a complete abdominal wall and scrotal transplant. So this is what led the charge. This is where I'd like to point out that this transplant could not have been done if we as a group didn't do 3 cadaveric studies. So we as a group, that entire team came together 3 times and did a donor and a recipient cadaver. So we could learn how to work together in this sort of setting. We had all worked together before in different oncological cases, different reconstruction cases, but not in the setting of this. So we did this 3 times as a recipient and a donor, and this was vital to our success because on the day of the transplant, we had already been through it, dry run 3 times. So everybody knew their position in the transplant and how we can do this. But the immunosuppression, I was a big disbeliever in the effects of immunosuppression on corporal tissue. My lab for many years has been very interested in corporal smooth muscle biology and endothelial cell biology. And I raised the question, well, what agents should we use? And can the corporal tissue actually respond to pharmacological stimulation after undergoing ischemia for potentially 16 to 24 hours? So why is this important? Because the allograft that we used actually the recipient was actually in the Northeast. It was removed by Bud Burnett. So Bud did the recipient, and then I was at the donor dissecting out the urethra and the stump of the penis. So for us, I said, well, could the corporal tissue survive this? And the reality is that these that we had to come up with a way to do a composite allograft with appropriate immunosuppression that would allow the patient to have less rejection. I'll show you the data for the use of FK506. I'm not going to show you the data for this because this is actually work that was done in our transplant immunology lab, where we actually isolated bone marrow from the donor and actually gave it back to our recipient in post-op day 14 to increase donor tolerance to the graft. Why is that important? Because we were able to pull off immunosuppression because this patient had already been presented with antigens from the donor, so it allowed him to have less rejection. So at the time, I had a very bright MD PhD in the lab, Nick Sopko, and my postdoc, Hotaka Matsui. They were working on some immunology and cancer immunology, and we said, well, can we design an experiment to test the hypothesis of the ability for the corpora to actually undergo ischemia and be able to respond to different immunosuppression agents? This is a hard schematic, but let's break it down. We took corpora cavernosa from a patient of mine and Bud Burnett's that underwent an IPP. We put it in media, and then we gave the PBMCs from the patient that we took the corpora cavernosa to, combined it with that, and this was our autograft, and then we did media, and then our allograft, which is a rejection. We used Hotaka, who was from Japan, so we figured there was going to be no HLA, there was going to be HLA incompatibility, and he was the allograft, PBMCs. So in the lab, corpora cavernosa with the patient's PBMCs, corpora cavernosa with Hotaka's PBMCs, which is the allograft, which is the rejection. And what we were able to do is actually show that if you do a autograft, which is the patient's own PBMCs, so this is going to take, we were actually able to show that the corpora cavernosa, despite being in media for 24 hours, actually still responded to pharmacological stimulus. And it was able to release, and it was responded to electrical field stimulation. So the nerves were still present, they were releasing neurotransmitters, and it responded to pharmacological stimulation. And if the patient had an allograft, so the rejection, it responded less. So this established our model. We then did a series of experiments to show that if you added immunosuppression agents like cyclosporin or FK506, we were able to prevent T-cell activation, innate and adaptive immunity to reject the tissue. Now, this is the most important experiment because we then started to use different agents. Cyclosporin, which is traditionally used for immunosuppression, and FK506 or tacrolimus. And what we found is that cyclosporin would not be the appropriate agent to use in our patient because the corpora cavernosa, in response to cyclosporin, when you added it, actually impaired electrical field stimulation and endothelial-dependent vasodilation. And what we did was we went back in the literature, as we all do sometimes, and in the 1980s, there was publications showing that cyclosporin prevented endothelial-dependent vasorelaxation. So if we would have just done a better literature search, we would have known that, but nonetheless, we were able to show it here. So we were able to demonstrate in the lab that FK506 would be our agent. So what did the ex vivo studies tell us? It told us, number one, is that the corpora cavernosa is pretty resilient, and it still responded to pharmacological stimulation as well as electrical field stimulation, and we felt like we had a better biological basis for the immunosuppression that we were going to use. So what about our patient? How did they do? Well, he was a military veteran, he is a military veteran, excuse me, who lost his phallus from a blast injury. He had multiple abdominal operations. He actually essentially had a perineal urethrostomy, and the penis was essentially retracted underneath the pubic bone. It was right where the cruce came together. He also had bilateral AKAs. And this patient simply stated to us that he wanted to be able to urinate, stand up and urinate. That was really his goal of this. And he wanted to look normal, as Andrea said. He wanted to be able to function normally. I'll add that preoperative assessment by CT scan to look at the vascular anatomy was super important for my colleagues that did the vascular anastomoses because it allowed them to be able to know what our patient's vascular anatomy was so they can do appropriate anastomoses. This is just a cartoon showing the different anastomoses that were done. So, this was 16 vascular anastomoses that were performed from the external pudendal, different branches, as well as the cavernosal and dorsal arteries. We also dissected, so my job is in this transplant was to dissect out the corpora cavernosa and get the urethra prepared. And what I was able to do is identify the cavernosa, the dorsal artery, nerves, and veins. So these were done by my plastic surgery colleagues. So what did the patient look like prior? So this is our patient here. This is actually his urethra is here. This is sort of where the penis is. I want to point out that this is actually skin grafts that are over it. There was about a couple of inches of skin graft and scar, and actually the penis was retracted underneath the pubic bone. So this was essentially what we started with, and then this is the final product at the end of the day. We started at about midnight and we finished at about 4 o'clock. So this was different shifts of people doing it. The urethroplasty was a primary urethroplasty that we performed, and we actually did the penile corpora cavernosa and urethroplasty first, and then they did all the anastomoses. So thus far, he's not rejected. It is functional. He has normal voiding patterns, and he has partial erections. He's not sexually active. He does not have a partner. So in summary, penile transplant offers improved cosmesis and function. I will point out this takes a significant amount of time and effort by a group of people. This is not going to be led just by urology. And there is inherent bias and ethics associated with this. And I think we as a community have to acknowledge that. And before we can overcome sort of this barrier, we have to come up, I believe, with regulations for this. And that has not happened thus far. And the utility in clinical practice, I will tell you, is unknown. I can tell you, I can't imagine that this is going to be like a kidney transplant, but I think in specialized centers for appropriate patients, this may be possible in the future. Thank you.